several different jobs. My main job is that I'm an educator, a teacher. We have a fellowship where I work, and we're training future surgeons on laparoscopy and robotics. I'm a urogynecologist. I've been in practice for more than 20
That's amazing.
years.
So it was interesting that you talk about, the fact that even though you do robotic, laparoscopy, manual laparoscopy is not going away. It's not going to disappear.
Right.
Tell me a little bit about that and how you kind of decide what you're going to do, robotic versus manual laparoscopic. I think that's interesting.
So as the primary surgeon, I have to choose between the laparoscopy and robotics based on, one, my access to the robot. Now, since I'm the chief of surgery, I can choose my own grid, but not all surgeons have that, right? You get limited access to robotics time. Not every OR has a robot. But also not every surgery is appropriate for robotics. It's a big, expensive device. It takes a lot of resources. It's got limited lifespan for its arms. And so, simpler cases are really more appropriate for laparoscopic surgery. The room turnovers are faster for laparoscopic surgery. So really something like a gallbladder, or for me, a tubal or a minor endo excision is really a more appropriate laparoscopic surgery. And then anything bigger, like a sacrocolpopexy or a really complex hysterectomy maybe, or even a myomectomy would be more appropriate for the robotics just because of the finer dissection capabilities and the increased magnification.
So that's a word that you said, it's about efficiency, turnover, speed.
Right.
So you make a kind of a judgment call based upon, okay, versus how complex, how much precision, how long the case is going to be, what's the setup piece of it and the flow of it. How much pressure is there sort of nowadays in your health system to make sure that you are extremely efficient and don't lose cases, or you can maximize cases?
Yeah, that's extremely important. I'm running an entire OR of only 10 rooms. I can't build additional rooms into the operating room. So, that's the case with most hospitals. You're going to have to use the ones that you have. Some may have 20, 30, some may have 2. And there's not a robot in every room. I also have to share it with all of the surgeons that I have in the department. So thoracic surgeons use the robot, and general surgeons, colorectal, urologists, and gynecologists. And so the first thing I do is look at what types of procedures they're doing and how far out those surgeries are booked. For instance, prostate surgery, right? You don't want your prostate cancer patients waiting 60 or 90 days to have their case. And so recently we've realigned our grid so that the urologists could have more time to pull those cases forward and do those critical patients. And really, they use the robot for those cases. No one's doing laparoscopic prostatectomies, really. Intuitive and Da Vinci are the gold standard for the robot prostate. And so then I can shift my GYN team to do more of their cases laparoscopically because we're all fellowship trained in minimally invasive surgery. I have that flexibility. Other teams, not so much. You may have some surgeons that are really only skilled robotically, and then you have to decide who gets what time, how far out is it okay to book those cases, do we need to acquire another robotics platform, is there something that I can make in terms of more efficiencies, do I send more teams to help room turnover faster so that they can book more cases? Can my sterile processing department process all these trays? You have to think about all that in terms of using those robots, which are limited resources.
It's a program, right? It's not just about a robot, it's a program.
It's an entire program, right?
Yeah. So interestingly, you talked in there as well about education. We still have to train the next generation of surgeons to come through. We will need surgeons working on us in the future, there's no doubt about it. I mean, and how important it is for them to get, the full access to all the spectrum of procedures, not just sit there and watch robotic procedures, for example.
It's actually become really difficult because if you remember when robots first started, all of the attendings needed to train first. And so those trainees really got minimal time on the robot and so subsequently had to do fellowship. So I think now they are able to start training on the robot much earlier in their training program, but now we're losing out on training for laparoscopy and, in my field, in vaginal surgery. And in fact, recently our institutions for education said we actually have to also provide more open surgeries for those because that's a skill set they're really losing.
Yeah.
So
when we talk about programs and we talk about residents and we talk about the start of the career and importantly, the end of the career, okay, one of the things that I've seen over my 30 years of watching laparoscopy is the toll that laparoscopy actually has from a physical point of view. And 30 years ago, it was just like, get on with it, right?
Right.
Suck it up. Tell me a little bit about the role of fatigue and ergonomics and what your thoughts are around that.
So certainly you get more fatigue with laparoscopic surgery, especially the shoulders and the neck and even the hands. If you're gripping the instruments, I've found that a lot are not made for smaller female hands as well. And you don't have that necessarily with your robotic instrumentation. So I think for a surgeon who's very high volume, they're going to likely gravitate more to something that makes them feel more comfortable by the end of the day, either physically, but also mentally. Is there anything in the surgery that's making it easier for them? How much assistance do they need? Do they need to leave where they are and move to the opposite side of the table and then operate with their less dominant hand? Or how great is their assistant in terms of assisting and holding that heavy camera? By the end of a long case, that camera starts to get really heavy. So I think ergonomics are really critical, and we have not paid attention to that, like you've mentioned. It's not unheard of that I've had, many surgeons tell me in their later career that they've had neck surgery to correct because they're constantly leaning down. So it's important to consider that.
And you mentioned about holding a camera for a long time, and I've done it in the past and for a very long time, and I've been slapped on the wrist many times by people. But I think it's underestimate a little bit of having a good image where the horizon's not drifting or it's not shaking around.
Right.
These all add to fatigue. So, having a good stable visualization system where you have a good stable image, I mean, how important is that really, to an operator, especially when you're doing a lot of cases in a day?
Well, it's funny. I actually, when I operate on the outside in my non-major job, I have a surgical assist, and she's actually training to be a first assist, but really she's just a scrub tech. And so right now I'm having to train her to hold the camera upright, and constantly we're shifting our head, and I'm like, okay, watch how you're looking, turn that back. And so it's very fatiguing all day long. It slows down the surgery. It makes us all tired. I don't want to have to be repetitively reminding her to do that. She'll eventually get it, but it is a toll on the surgery for both of those reasons, time and fatigue.
And is that, with that kind of tech, are they also trying to manage the back table and at the same, so they're kind of an octopus?
Yes.
Yeah,
they need 3 arms. Surgeons need 3 arms. The techs need 3 arms as well. Yeah.
And how is it for staffing at the minute? Are you struggling to get staffing? Are you having staffing issues?
We do have staffing issues. We were on a hiring freeze last year, and now this year we're still struggling to hire. It takes quite a bit of time to get people through all the regulations to get them hired, and they may not stay very long. It's difficult to train them, so it's a constant turnover process, which slows you down. I can't even open my 4th room at my ambulatory surgery center right now because I don't have techs to staff it. Yeah,
that's
challenging.
Again, that's very challenging, especially if you've got, you've paid for the space, you're paying for the lights and the air, and you're not utilizing it. Yeah, exactly.
It's all sitting there.
It's all just sitting there.
The patients are waiting. You just can't run the room.
You can't get them through. I do think that's where technology can potentially help us. And there's 2 parts to technology. There's the physical part of like the robots or the Maestro system or whatever. But a bigger piece that I see now is the data and the information. I think if you're running your business, and it's a business, and you're running your program, I think the more data you get, the more you can make decisions. Would you say that's true?
Yes. So I can decide, do I need to add footage to SPD to run more instruments through? How many can they process in a day? Do we need to add another ultrasonic cleaner? What's communicating with my nursing staff and pre-op to let me know that the next patient's ready to go? Is that feeding into my FMS team that's turning the rooms over? Am I analyzing the grids with any sort of AI right now to tell me, should I move some of the surgeons around to make better use of the robot? Right now I'm doing that by hand.
Okay, so having a dashboard where you can just pull open a dashboard would be great.
I need to plop it all into Gemini and say, what should I do for the next grid modification?
Yeah, well, I think that's a message to all the robotics companies, all the tech companies out there, give you the information in insightful ways, not just give me data dumps, give me insights that I can act on.
Right, actionable items. And then I'd like it eventually to also follow the patient through the whole healthcare journey.
Right.
Not just right now in my tiny world of the OR, but even as they follow into the hospital system and then after discharge. All of that should be connected in the future healthcare system.
Okay. One last question that I'll talk about as well is that we were going back to the staff and the turnover of staff and trying to find staff. I think a piece that is often neglected, I've seen this over years and years, is that those staff need to be trained.
Right.
Right? So in your ideal systems, when you introduce a new technology, do you want it to be really complex so that you have to train them up and have overtrain, or do you want to make it so that it just fits into your flow? What's kind of, I know it's a loaded question, but
Right.
but I think people don't think about it enough. We introduce technologies and just, again, hey, let everyone get trained. What's your experience been over introducing complex things like robots or different technologies?
I mean, I think right now it mirrors what we're doing with trainees, where we have a dedicated program that they do either from the company and then edited by us, or they spend a certain amount of time watching, doing parts, and then they can finally integrate. So that may take many months depending on how complex it is. If we had it simpler, I could hire and then start them the next week. Right
Yeah.
now it's a 2-month process for me to get someone really trained just to assist or scrub in the OR.
And you obviously don't want to be having to send them off to some training center somewhere for 3 days, because that's downtime for you, right?
Right.
So the more that companies can try and bring the training to you, simplify it and make it easy, that's going to make your life easy for introducing technologies.
Exactly.
Okay, good.
Yeah.
All right, well, thank you very much for being here today.
It was really nice to talk with you. Thank you so much for your time.
Okay,
Awesome.
good. Oh,
Thanks.
that was easy.
Yeah.
Excellent.
Well, you made it easy.
No.
Thank you. Thank you. That was great.